Welcome to this explainer. You know, when a lot of nursing students first hear the word epidemiology, they instantly picture dry math, endless spreadsheets, and, well, dusty textbooks. But I'm here to tell you it couldn't be further from the truth. Epidemiology isn't just crunching numbers. It's thrilling, high-stakes, real-world detective work. As a nurse, you're right there on the front lines. Unlocking the secrets of epidemiology, that gives you the power to track down invisible threats, stop outbreaks dead in their tracks, and ultimately save lives in your community.
Our source material actually puts it perfectly. Epidemiology is true detective work, and I really want you to adopt that mindset right now. Just imagine stepping onto the scene of a sudden outbreak. People are getting sick, panic is starting to brew, and it's totally up to you to figure out the who, what, where, when, and why. You aren't just treating symptoms at the bedside anymore. You're investigating the distribution and the determinants of disease across an entire population. You, my friend, are hunting for the culprit.
Okay, let's dive into this with Section 1, Incidence versus Prevalence, and building your detective toolkit. So every good detective needs a reliable toolkit to make sense of the clues, right? For a nurse epidemiologist, that toolkit starts with understanding how we actually measure sickness in a population. We really need to distinguish between what's newly happening right now and what the overall picture looks like. To do that, we look at two incredibly important concepts: incidence and prevalence. Think of incidence as tracking the newly emerging clues of an outbreak. It measures the number of new cases or events developing in an at-risk population over a specific period of time. It basically tells us how rapidly a disease is spreading right now. Prevalence, on the other hand, is more like taking a wide-angle photograph of the entire crime scene. It measures the total existing cases in a population at a specific snapshot in time. So if you want to know your risk of getting a disease today, you look at incidence. But if you want to know how much total disease burden a community is currently carrying so you can plan healthcare services, well, you look at prevalence.
Now, when we're dealing with a sudden localized outbreak, like an infectious disease or food poisoning, we use a very specific type of incidence called the attack rate. The attack rate is simply the proportion of people who were exposed to a specific agent who then actually developed the disease. It's great because it cuts right through the noise and tells our nurse detective exactly who got sick after a very specific exposure.
We've talked about how we track who's getting sick, but as healthcare professionals, we also have to confront the most severe outcomes. So how do we measure the ultimate stakes of a disease when lives are literally on the line?
That brings us to Section 2, measuring mortality and risk and understanding the denominator.
When we measure mortality and risk, the secret to the math is always understanding your denominator. You can't just look at the raw number of deaths, the numerator. I mean, 50 deaths in a town of 200 people, that's a catastrophic epidemic. But 50 deaths in a massive city of 2 million, that is a very different statistical reality. To understand the true risk, you have to divide the number of events by the actual population at risk. Our source outlines several key mortality rates that nurses use to do this. First is the crude mortality rate, which is just the proportion of a population who die from any cause during a specific period. Then we narrow it down with the cause-specific rate, which looks at deaths from one specific disease within that total population. But what if you want to know the survival rate of the disease itself? For that, we use the case fatality rate. This is the number of deaths divided specifically by the number of people diagnosed with that exact disease. Finally, the infant mortality rate tracks deaths of infants under 1 year of age against live births. And interestingly, this one is actually used globally as a major indicator of a community's overall health and access to care.
Now, definitions and math are great, but let's be honest, they're kind of just abstract concepts until you apply them to a real urgent situation. So what happens when an ordinary church picnic turns into a public health crisis? Let's put on our detective hats and look at a real-world scenario. Welcome to Section 3, Case Study, the Church Picnic. Time to analyze the crime scene.
Let me transport you to Warren County. It's a totally normal weekend, and the local church is hosting its annual potluck picnic. 200 people attend. Sounds lovely, right? But shortly after, the local health department gets a frantic call. Out of the 200 attendees, half of them, 100 people, have suddenly fallen violently ill with diarrhea, nausea, and vomiting. 10 of them even require emergency medical treatment. Nurse epidemiologist Mary Miles arrives on the scene. And this brilliantly illustrates the math we were just talking about. With our numerator of 100 sick attendees and a denominator of 200 exposed, Mary instantly knows her overall attack rate is exactly 50%. This makes the concept of incidence completely concrete. Literally half the people who walked into that picnic got sick. Now she has to find out why.
An absolutely crucial piece of data for any disease detective is the incubation period. That's the time between the actual exposure and when the symptoms start showing up. Mary's data shows that the attendees started getting sick anywhere from 1.5 to 30 hours after the picnic, with the mean, or average, onset landing right at 6 hours. This is a massive clue. It tells our nurse exactly when the metaphorical crime occurred and strongly points toward a foodborne pathogen, which, as you know, is pretty common in potluck settings. So Mary turns her attention to the buffet table to line up her suspects. We've got the Joneses macaroni casserole, the Smiths turkey and gravy, the Chang's potato salad, which, let's be real, is always highly suspicious at an outdoor picnic, plus chili, homemade bread, and cake. Mary interviews the sick members to calculate food-specific attack rates. Basically, she wants to know the incidence of illness specifically among the people who ate the potato salad versus those who didn't, and so on down the line. It's a rigorous, step-by-step epidemiological process of elimination.
Well, the data points cleanly in one direction. She finds a huge association with 3 specific items: the turkey, the gravy, and the stuffing. Mary interviews the Smiths, the folks who brought those dishes, and boom, she uncovers the smoking gun. The turkey had actually been allowed to cool for 4 hours at room temperature right after cooking. And to make matters worse, the same utensils were used before and after cooking. So the specific food attack rates led Mary directly to improper food handling, which gave bacteria the absolute perfect time and temperature to grow and produce toxins. Mystery solved.
But here's the most important part of this explainer. The job of the nurse epidemiologist doesn't just end when the culprit is found. I mean, data is just data unless it actually protects people. So how do nurses use this incidence and prevalence data to stop the next outbreak from happening?
Let's move to Section 4, Evaluating Community Health Interventions. Moving from data to action.
Gathering all these attack rates, incidence numbers, and mortality statistics is absolutely vital, for sure. But it's really only useful if it serves as the foundation for effective, life-saving public health interventions. Nurses use epidemiology to evaluate exactly what a community needs and how to fix it. Let's see how this builds into a structured framework for community assessment. First, nurses examine the epidemiologic data, those rates we just discussed, to clearly identify the problem. Then, they consult community leaders to understand local perceptions. They analyze environmental hazards like improper food storage or maybe polluted water. They identify cultural beliefs that might impact health behaviors. And finally, they engage the community directly to create workable solutions. It's a really holistic approach that turns cold, hard numbers into compassionate community action.
We generally map these actions across 3 levels of prevention. Primary prevention stops the disease before it ever happens. Think immunizations or education. Secondary prevention is all about early detection, like health screenings and testing. And tertiary prevention focuses on rehabilitation and limiting disability for those who are already sick. In our church picnic case, Mary Miles didn't just solve the case and walk away. She utilized primary prevention. She sat down with the Smiths to teach proper food handling, and then she went a step further and offered a food safety class to the entire church congregation, all to ensure an outbreak like this would never, ever happen again. And honestly, that is the true power of epidemiology in nursing. It's identifying the clues, running the numbers, and stepping in to protect the public. So as we wrap up this explainer, I want to leave you with this question. Are you ready to view your own community through the lens of a disease detective? Take a look around you. How might incidence, prevalence, and mortality data change the way you see the health challenges in your own neighborhood? Start asking why, start looking for those denominators, and you'll be amazed at the solutions you can uncover. Keep learning, keep investigating, and thanks so much for joining me.